Hello and welcome to our podcast. My name is Francesca. I'm a consultant urologist at King's College Hospital in London with an interest in endourology, mainly BPH and stones. I would like to welcome today Dr. Richard Hindley, who is a consultant urologist at Hampshire Hospitals. The focus of our podcast today is looking at water vapour therapy, the more than 5-year outcomes in clinical data, and also the clinical experience. So Dr. Hindley, how long have you been offering water vapour therapy for your patients?
So I actually performed the first case in the UK in March 2017, so it's over 6 years now. It's really flown by, and it's been a really interesting and exciting journey.
Excellent. And so which patients do you think are suitable for water vapour therapy in your opinion?
Ideally, I think the biggest cohort of patients for whom it's suitable is the sort of younger man keen to retain sexual function, who's working and has a gland volume in the range of 30 to 80 mils. I think that there is a second cohort of patients that we might consider, but I think that depends what other BPH treatments we're offering at our institution, and that will vary around the world. So I can see potentially a role for offering a minimally invasive procedure, such as water vapour therapy, where you can do it under a local anaesthetic, that you might offer it to a patient who isn't perhaps fit for a general anaesthetic.
Great. And your experience so far, what tips and tricks and what things would you pass on?
Yeah, so I think it's been a real journey for me, and as the first person to be doing the cases in the UK, I guess I was leaning more towards over-treatment because I was really keen to show that there were, that it worked. But, running with a minimally invasive treatment, I think it does make you really more patient focused, and you're really looking at what the patient's concerns and requirements are, and you can adjust the water vapour treatment according to the needs of the patient. It's versatile in that way. Mm-hmm.
So it's great that I've seen that it's adaptable, and from reading kind of clinical outcomes and clinical literature, I know that you've published a few clinical outcomes, etc. Can you tell me more about that, and also what's been published kind of globally, etc.?
Yes. So the Pivotal 2 study was published, and that was a randomised trial, 2-to-1, active treatment versus sham, and the 5-year outcome data has now been published, and that's very good in that there's a consistent improvement in symptoms, which is maintained out to 5 years with low retreatment rates. The results are very much in line with the studies that had gone beforehand, so that the results appear to be reproducible. Compared to some of the other minimally invasive treatments, perhaps we need more randomized trials. In terms of my own experience, we did publish our sort of real world outcomes, the first 461 patients that we treated, and that was obviously there were some patients with gland volumes bigger than 80 mils, a small proportion, 10 to 12%, were in retention. So it was a real sort of warts and all real world experience. But I think the results that we got with that were very good. And in fact, the IPSS reduction and Qmax improvement, not that that's so important, were, if anything, better than in the randomized trial. And now that there is more real world data. There was a Swiss publication recently in print, and there's data coming through on patients in urinary retention, for example. There is a randomized trial in the UK due to start any time now called Premise, which randomizes between TURP and 3 minimally invasive treatments, including water vapour therapy.
So moving on back to you published about the 460 patients and your patients in acute urinary retention. So they're of course a cohort of patients who would otherwise be potentially with a long-term catheter. What was your experience on that?
I think we were pleasantly surprised in that we had 80% of our patients catheter-free by 6 weeks. I think it's better to be focusing on those with acute painful retention rather than chronic painless retention. And our results that we are in the process of submitting for publication are in line with the 5 or 6 other published papers in the literature. I think there is one prospective study and 4 or 5 other retrospective studies, so modest numbers, but in terms of the range, I think it ranges between 70 and 100% catheter-free. Clearly, drawing on the experiences from other minimally invasive interventions, patient selection is really important. But I think as a potential role for the future, if we can often these minimally invasive treatments under local anaesthetic, and we know the waiting list problems that exist, and patients, often young men, waiting several months before their operation with a catheter or performing self-catheterization, there might be a real opportunity there for men, after failing their trial without catheter, to be offered maybe 2 weeks later a local anaesthetic minimally invasive treatment.
That's great. So moving on to more about your protocols and what you offer your patients, do you do most procedures under general or local? And just tell me, as if somebody were to be starting out their service, what would your best advice be?
So my journey, as a personal journey, has evolved over time. Obviously the learning curve, the first few cases, you want to do them under GA ideally. And I was basically following what the US and what we're doing, and my mentor, I guess, from Sweden, I was sort of taking their advice. Initially, we were perhaps performing 2/3 of the cases under LA, often with sedation, and about 1/3 under GA. It's evolved over time. I think it really does come down to the environment. So I'm still doing cases under LA. We're using topical gel, using initially transrectal, but now transperineal LA. But also another option is to use, fentanyl, midazolam, and topical gel, so that, there are different approaches. But I think it really does depend on the country you're working in, the environment you're working in, what do you have at your disposal? And in the UK healthcare system, there are many hospitals that don't have the right environment or space to be doing these cases, but that's all in the process of changing, as we know.
Tell me more about patients' expectations and how you manage those with all of our BPH modalities that we have to offer.
Yes, it does require a proper conversation, and I think as clinicians we need to get better at listening. We need to be very patient-centric and not say, well, this is the procedure I offer, that's what you're getting, because those patients will be disappointed and they'll go elsewhere, or if you do treat them, they're less likely to be happy with their ultimate result. So it's a case of understanding what their issues are, but obviously as doctors we want to know, what is the prostate volume, what is the flow like, do they have detrusor dysfunction, how severe are their symptoms, what are they particularly worried about, what are their demands. And for example, if a patient isn't worried about preserving sexual function, that seems like a small proportion of patients to me, then maybe we should be looking elsewhere if they've got a larger prostate gland and looking at one of the laser therapies. So I think there is work being done on shared decision aids, and I think that will help inform that discussion. And in the state healthcare system, we always have those real limitations on our time in a clinic. But some of that work increasingly can be delegated.
Moving on from decision aids, then, how do you see that water vapor therapy fits in amongst all the other treatments? It's
versatile. It can treat patients with a trilobar prostate gland or a bilobar gland. There are a number of publications in the literature, which I didn't mention earlier. Once one gets over 100 mils in volume, in the discussion, there's usually another option that might be better.
Any final advice that you would like to give those of us who will be starting out water vapor therapy in our practice?
I think this technology is very versatile, and it's very unlikely to impact on sexual function. It's very unlikely to cause harm. At the most common, the reality is, at first do no harm, and most patients get good benefit. I think in an effort to stay safe with the treatment, it would be to follow the prescribed, recommended teaching for doing the treatment itself. I do point out to patients that if they've got a middle or median lobe, that they are perhaps a little bit more likely to have some symptoms in the early post-operative period, and then maybe a little bit more likely to produce small amounts of tissue or debris. So it's definitely in my mind. I think that overall, patients with a bilobar gland have a little bit of an easier time of it than those with a trilobar gland. So I think that would be an important word of advice.
Thank you very much, Dr. Hindley, for your expert advice today. So we hope you've enjoyed this podcast today and have learnt a lot. So far we've covered hopefully a bit more about how water vapor therapy features, where we foresee it going in the future, and a bit more about our real world data over more than 5 years experience. Thank you.